Welcome to The Code Tray, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We'll have Alice Tan, who is a PGY1 resident at OhioHealth Doctors Hospital, and she'll be presenting a journal club on the clinical impact of adjunctive fomepizole for high-risk acetaminophen overdose.
Here are the list of objectives that will be conducted throughout my presentation. We will be reviewing the literature supporting fomepizole as adjunctive therapy in acetaminophen overdose, examine the efficacy and safety outcomes of adjunctive fomepizole in high-risk acetaminophen overdose, and discuss the implications of these findings for emergency department management of acetaminophen toxicity. Here are the list of abbreviations that I will be using throughout my presentation. And just a little bit of a background, acetaminophen is the leading cause of acute liver failure in the United States, accounting for about 46% of all cases. At therapeutic doses, most acetaminophen is safely metabolized through glucuronidation and sulfation pathways. However, a small fraction is oxidized by the CYP2E1 enzyme to a toxic metabolite called NAPQI, and normally NAPQI is quickly neutralized by glutathione. However, in overdoses, the glucuronidation and sulfation pathways quickly become saturated, so unfortunately, more acetaminophen is shunted through the CYP2E1 pathway, and the glutathione stores are rapidly depleted. So the excess NAPQI then binds to the hepatocellular proteins, causing oxidative stress, mitochondrial dysfunction, and ultimately hepatocellular necrosis. This is the fundamental pathway that both NAC and fomepizole targets, however, just at different points. So speaking of NAC, this is our standard of care and has been for decades. It is nearly 100% effective in preventing hepatotoxicity when it is administered within 8 hours of acetaminophen ingestion. However, the efficacy drops significantly after 8 to 10 hours of ingestion. NAC works downstream. It replenishes intracellular glutathione so that there's excess detoxification of NAPQI, and it helps reduce the oxidative stress from that. However, there are well-described scenarios in which there are NAC failures. So high-risk features of NAC failure includes an acetaminophen level of 300 micrograms per milliliter or higher at greater than 4 hours of ingestion, or a multiplication product greater than 10,000 and the multiplication product of the acetaminophen level and the liver enzyme, or an ingestion of 30 grams or greater. Fomepizole is traditionally known as an antidote for methanol and ethylene glycol, and its proposed role in acetaminophen overdose is based on a dual mechanism. So first, it is a potent inhibitor of CYP2E1, which again is the enzyme that converts acetaminophen to NAPQI. And studies have shown that CYP2E1 inhibition reduces NAPQI formation by approximately 74%. And the second pathway and mechanism in which fomepizole prevents and helps with acetaminophen overdoses is it prevents the activation of the J&K pathway, which is a key mediator of mitochondrial dysfunction and cell death downstream of the NAPQI injury. So in theory, fomepizole provides both upstream protection by blocking NAPQI formation and downstream protection by preventing mitochondrial injury. However, despite this strong mechanistic rationale, the Canadian 2023 consensus statement on acetaminophen poisoning did not recommend the routine use of fomepizole, citing insufficient clinical evidence. Nevertheless, the use of fomepizole in acetaminophen poisoning has sharply risen over the years. It was used in 0.31% of acetaminophen toxicities in 2016 and 5% of acetaminophen cases in 2024. So before reviewing my primary article, I did want to give a brief background of the literature that helps drive the interest of fomepizole. So this article was published in a clinical toxicology journal, and it looked at fomepizole as an adjunct therapy for acetaminophen poisoning, and it looked at case reported to the ToxIC database from 2015 to 2020. So the objective of this article was to characterize real-world fomepizole use for acetaminophen toxicity and describe the clinical patterns of who it was used on. It was a secondary analysis of the ToxIC database over a period of 5 years, and it looked at 25 patients who received fomepizole for acetaminophen toxicity. And the findings showed that the fomepizole was used in the sickest patients. 72% of the patients had hepatotoxicity, 72% had metabolic acidosis, and 40% developed coagulopathy. 48% were intubated, 36% needed vasopressors, and 24% was on CRRT, and the overall mortality of these patients was 24%. So again, this study demonstrated that fomepizole was being used in critically ill patients with severe toxicities. However, because there was no control group, it's hard to determine whether or not fomepizole actually improved the outcomes or simply reflected the treatment of the sickest patients. Another article published in Clinical Toxicology was a prospective case series. It was fomepizole as an adjunct to acetylcysteine treated acetaminophen overdose patients, and this was to look and evaluate the safety and outcomes of fomepizole plus NAC in high-risk acetaminophen overdose patients. Again, this was a prospective case series, and it was single-centered, looking at 14 patients. The patients received 15 milligrams per kilogram dose, followed by a repeat dose at the discretion of the toxicology service. And overall, the findings show that there were no unfavorable outcomes that were reported, and the authors concluded that fomepizole appeared safe in this population. So while it is encouraging to recognize the study that there were no unfavorable outcomes, it is important to note that this study is also not controlled and involved only 14 patients, so the absence of adverse outcomes do not necessarily establish the efficacy of fomepizole. So that brings me to my article, the clinical impact of fomepizole as an adjunct therapy in high-risk acetaminophen overdose. The study objective was to characterize and compare clinical outcomes in patients with high-risk acetaminophen overdose who received fomepizole as an adjunct to NAC treatment to those who only received NAC. As for the study design, this was a retrospective observational cohort study conducted across 4 poison control centers in the United States between January 2018 to December of 2020. The investigators utilized the National Poison Data System case records, which allowed them to identify patients who received fomepizole and compare them to patients who received NAC alone. The inclusion criteria were designed to capture high-risk acetaminophen ingestions, so patients had to meet at least one of the criteria of acetaminophen level greater than or equal to 300 at 4 or more hours post-ingestion, or a multiplication product of 10,000 or greater. And of course, all patients must have received NAC. The exclusion criteria were chosen to reduce confounding variables, so they excluded patients who had co-ingestion of a substance where the treatment of fomepizole may also be indicated, patients with a history of alcohol use disorder, underlying liver disease or cirrhosis, co-ingestion of another hepatotoxic substance, and cases with insufficient documentation were also excluded. The primary outcome of the study was MPTS medical outcome severity, which is a standardized ordinal scale assigned by trained toxicologists, specialists for all poison center cases. It categorizes the patient medical outcomes as either a minor effect, moderate effect, major effect, or death. The secondary outcomes of the study looked into NAC treatment duration and whether or not the patient had an ICU stay. For data analyses, ordinal outcomes were evaluated using ordinal logistic regressions. Binary outcomes were evaluated using binary logistic regressions, and NAC duration was evaluated using Poisson regression. All models were also conducted using a doubly robust regression approach to address any confounding variables. As for the results of my study, there were 1,158 cases that were identified through ToxSentry database query. Of those, 124 received fomepizole and 1,034 received no fomepizole and only received NAC. After applying all the exclusion criteria I previously talked about, there were 95 patients who received NAC that were included in the study, and 296 patients who only received NAC. So looking at the baseline characteristics, there were some notable differences and minor differences between the groups. So in the NAC only population, the median age of those patients was 37 versus the median age of the fomepizole group was 30. And there were also a higher percentage of patients in the fomepizole group that were female. There were 76% of those patients that were female versus 65% of those patients in the NAC only group that were female. More importantly, the fomepizole group had a significantly higher acetaminophen levels. The median initial acetaminophen level was 145 versus 93 micrograms per milliliter, and 33% of the patients in the fomepizole group had an acetaminophen level greater than or equal to 300 versus only 13 in the NAC only, and 92% of the patients in the fomepizole group had a multiplication product greater than 10,000 versus in the NAC only group, only 87% of them met that criteria. For the patients who received fomepizole, the vast majority of them, 96% of them, received a dose of 15 mg per kg, and also the vast majority of the patients received only a single dose. 5% received 2 doses, and 4% received 3 doses. So this slide shows some of the key clinical outcomes. Dialysis rates were similar. 7% of the patients in the NAC-only group received dialysis versus 8%. Interestingly, the number of patients who received liver transplant were different between the two groups. There were 6 patients, 2% of patients in the NAC-only group who received liver transplants versus in the fomepizole group, there were 0 patients who received liver transplants. And looking at the clinical outcome severity, the distribution of them appeared quite similar between the two groups at 18 versus 90% of the patients having a minor effect, 45 versus 41 having a moderate, 30 versus 34 having a major effect, and 7 versus 6% of the patients who received fomepizole having an outcome of death. So this slide also presents the primary outcome of patients who received fomepizole or NAC only. For the primary outcome of medical outcome severity, the odds ratio was 1.01 with a non-significant p-value. And similarly, there was also no statistical difference in the ICU admission between fomepizole and NAC only. and nor did the duration of NAC change for whether or not the patients received fomepizole versus NAC only. All of the confidence intervals crossed 1, suggesting that there was no measurable benefit for any of the evaluated outcomes. So overall, the primary outcome did not demonstrate improved clinical outcomes with adjunct fomepizole doses. A subgroup analysis was compared for patients who received fomepizole within 24 hours of NAC administration. There were 57 patients who qualified into that, and there were also 30 patients who received fomepizole greater than 24 hours after NAC administration. Again, there were no significant differences between the outcomes. The outcome severities were all across the p-value, all had a non-significant p-value and all crossed the confidence interval of 1. So overall, for key findings, this study does represent the largest comparative analysis of adjunct fomepizole and high-risk acetaminophen overdose currently available. However, despite the strong mechanistic rationale, the investigators of the study found no improvement in outcome severity, ICU utilization, or NAC duration. And additionally, earlier administration also did not appear to improve outcomes either. So when taken together, these results suggest that the theoretical benefit of fomepizole unfortunately may not translate to measurable clinical benefit for the broader population of high-risk acetaminophen overdoses. Something else that I wanted to touch on was cost when evaluating this adjunct therapy. So a single dose of fomepizole can cost roughly $1,000 to $1,500 per dose, which is one vial, whereas a full standard IV NAC regimen is typically under $200. So when a therapy carries substantial costs, we also generally want to save those for when there is strong evidence supporting improved clinical outcomes before adapting them into routine use. So given the absence of the demonstrated benefit in this study, the cost effectiveness of routine fomepizole use could be hard to justify. Overall, the authors concluded that the routine use of fomepizole in high-risk acetaminophen overdose is not supported by the available evidence. Importantly, there was also no significant safety concerns that were identified, which is pretty consistent with the previous cases and articles that I talked about earlier. The author also suggests future research and more randomized control trials, but specifically identifying patient populations who may have some greater benefit, such as patients with delayed presentations, with depleted glutathione reserves, and higher risk pharmacogenomic profiles. Some strengths of this journal article was that it is the largest comparative cohort study to date with a total of 391 patients. Second, the multi-center design across 4 different poison control centers improves the generalizability of the study. Third, the inclusion and exclusion criteria were clinically relevant. They captured high-risk patients while excluding patients with confounding variables like patients with liver disease and alcohol ingestion. And fourth, the subgroup analysis of fomepizole by timing does add an additional layer of analysis. There were quite a few limitations in this study, however, that we need to consider. The study, again, was retrospective and not randomized. And with only 95% of patients receiving fomepizole, the study was underpowered to detect small to moderate effects that could potentially still be clinically meaningful. The reliance on poison center data also introduces potential for incomplete or inaccurate information, as reporting was voluntary. And there was actually also no data available on activated charcoal use or high-dose NAC protocols, both of which could have influenced the outcome of the patients. Fomepizole timing again, was also only recorded as a binary variable of whether or not it was given before or after 24 hours of giving NAC, and this limits the ability to assess any dose timing relationships of giving fomepizole. The NPDS outcome severity scale, while it is standardized, it also does not capture all the dimensions of acetaminophen toxicity. And finally, there was also a difference in baseline characteristics between the two groups. The fomepizole had higher acetaminophen levels and were sicker at baseline, suggesting that there could have potentially been some indication bias by the providers. So what does that mean for our practice? NAC still remains standard of care for acetaminophen overdoses, and based on current evidence, routine addition of fomepizole might not be recommended. Given its significant cost and uncertain benefit, fomepizole should be reserved for select high-risk cases, ideally in consultation with a toxicologist or poison control. And it might include patients with extremely high acetaminophen levels, delayed presentations, or those showing signs of clinical deterioration despite NAC treatment. I would be interested, and we should be watching for ongoing randomized control trials, which will provide us more definitive answer on the routine use of fomepizole. But until then, the evidence does not really support the use of using fomepizole routinely and does not support changing our standard practice. That is the end of my presentation, and I would love to answer questions that this group might have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.